Good afternoon. Hi, everyone. I think we're going to get started because it's 2:30 now, so don't mind me. I've never done this, so I just want to welcome everyone. Thank you for coming to our symposium for Growing Up is Getting Old. I appreciate you all showing up. And I also want to say Happy Respiratory Care Week to everyone, to all the respiratory care professionals out there who do so much every day to keep our patients breathing well. We appreciate you. My name is Jen Sherwood. I'm a respiratory therapist at the U of M Adult Cystic Fibrosis Center. And then my co-chair is Dr. Gemma Stanford. And she'll get a better bio later because she's also one of our speakers. So we will get started here. As many of you know, people with CF are now living longer than ever before, which is obviously amazing news. But it also means we're facing new challenges as the population ages and we are seeing more individuals being diagnosed with CF later in life. I know our center, we're getting new, older diagnoses every day. I don't know how the rest of you are feeling, but I feel like we have one or two older CF diagnoses every week lately. So in today's symposium, we will look at how aging with CF affects the whole person beyond just lung function. We will explore the impact on musculoskeletal health, mobility, mental health, and overall quality of life. Topics will include advanced lung disease and optimizing lung function, sarcopenia, joint pain, changes in functional ability, and we will also discuss the mental health concerns such as anxiety, depression, and the emotional challenges tied to life transitions, including employment, relationships, and end-of-life planning. One of the highlights of our symposium is the opportunity to hear from a woman living with CF who will share her personal story and bring to life the real-world experiences behind the clinical realities that we discuss. So by the end of our time together, you will walk away with practical strategies to help maintain physical health, optimize lung function, and support emotional well-being, all with the goal of improving the quality of life for adults with CF as they age. Let's see, got to do my little disclaimer here. And I have nothing to disclose. These are learning objectives today, which I just kind of covered in our intro. So our first speaker today will be Dr. Gemma Stanford. She is a clinical specialist physiotherapist in adult cystic fibrosis at the Royal Brompton Hospital in London, where she has worked since 2005. She completed her PhD in 2024 and is the lead coordinating investigator for the current UK Yoga CF trial, which is investigating the effects of yoga for adults with CF. Gemma is the chair of the European Cystic Fibrosis Society's Physiotherapy Specialist International Interest Group. That was a lot to say. And the part of the International Reach for CF collaboration. Then we have Deb Bennett. She is a clinical social worker at Stanford Medicine's CF program, currently working in the adult clinic. She formerly worked in Stanford's CF program as a pediatric social worker. Besides the regular medical social work role, Deb has also started providing individual therapy to people with CF who are unable to access mental health through their insurance. She has been trained in CFF's sponsored CF, CBT, and ACT for people with CF. And Deb is also a trained yoga teacher and feels passionate about the confluence of gentle movement and emotional well-being. Then we have Valerie Mumper. She is a board-certified cardiovascular and pulmonary clinical specialist and practices physical therapy with Keck Hospital of USC, primarily treating patients with cardiovascular and pulmonary dysfunction. She is also an assistant professor of clinical physical therapy and has taught within USC's Doctor of Physical Therapy program since 2013. And then finally, we have our patient, Daniela Pulcini Auli. She is a Brazilian-American diagnosed with cystic fibrosis at age 29 and now 52. She lives in Salisbury, Maryland with her husband, Perry, and their 4 cats. She works part-time as an immigration attorney and is passionate about gastronomy and CrossFit. She is here through a video that we have. And then we're going to have 5 minutes of question and answers after each speaker. And then at the end, if you would like to stay, we're going to have like a 10-minute panel discussion where you guys can ask questions and our speakers can answer those questions. So we will get started.
And just to say that you can ask questions on the Q&A app, or you can come to the microphone and shout as well, whichever one. We will move on.
Hi, everyone. So again, like you heard, my name is Deb, and I'm one of the social workers at Stanford Medicine Adult CF Clinic. And for those of you that are savvy enough to notice that I am wearing the same outfit as my profile picture, you get extra points. And I was trying to come up with a really good joke about aging and doing that, but I didn't. So I'm open to ideas later. I have no disclosures. So when thinking about my presentation, my goal was really, I wanted to give you guys some concrete takeaways. And I thought to best do that, I wanted to give you a bit of an introduction to kind of the mental health picture, and then give you some possible strategies you all could use. So we will initially look at depression trends across the CFF centers in 2024. Current topics impacting mental health of adults with CF, what the research is telling us. Current topics reported to in our clinic as well as other clinics. A quick introduction to evidence-based modalities that mental health professionals will use with people with CF. And an introduction to strategies for you all, for RT and PT. And then a brief putting that into practice here today. And then I have a couple slides with some resources that might be helpful. So starting with this slide, and I need to give credit to Crystal Fallon, one of the amazing nurse coordinators in our clinic, because she put this together for a meeting recently. The blue line that you see is rate of depression. So prevalence of depression in adults across the CF centers through the CF registry. So as you can see, if you're looking back at like 2016, there was a little bit of a peak at about 15%, then a solid decline to 2020 through 21. And then it spiked again last year back up to about 15% or a little bit higher than it was back in 2016. And as you all know, ETI was initiated in kind of mid to late 2019. So mental health for people with CF. A lot of you are probably familiar with the TIDE study that was published in 2014. It's the first notation down at the bottom. In this study, 6,088 patients with CF were interviewed or responded, and about 4,100 parents. And the big takeaway from this study is that the rates of depression and anxiety are 2 to 3 times higher in people with CF or caregivers / parents of people with CF than the average community samples. An additional study of 266 people with CF on ETI, the results of that, 7% reported incidence of anxiety, low mood, insomnia, brain fog, and reduced concentration. And the last point is CFTR modulators do not decrease depression and anxiety. And this is from kind of a physiological response, right? What the CFTR modulators do to the cells is not affecting depression and anxiety. It's not decreasing it, sorry. So fast forward to current day. As was already noted, and you all know, our people with CF are expected to live much longer lives and are already living longer than many of them had expected initially. So along with this comes kind of changing existential questions, right? The big questions. And these were published in 2023, as you can see, noted at the bottom of the slide. Questions such as, who am I now? A lot of people with CF kind of identified as sick people, and now they're feeling much better, and they might identify as well. people. This can also vacillate a little bit if somebody gets a new diagnosis, maybe CFRD, CF-related diabetes, they might shift back to feeling sick again. So a big question for people now with CF on modulators, effective modulators for them. One of them is, who am I now? An additional question is, can I trust this miracle drug to keep on working? It's a good question. We don't know that yet. How do I cope with my changing body? You all know that people on ETI in particular are experiencing changes in their bodies, right? Increased weight, a little bit more bulk. How will my disease progress now? Again, we don't have these answers yet. Who will look after me now? So a lot of patients are thinking, as I'm aging, as I expect to age, perhaps up until this point, they were relying on parents or older caregivers. And now they're questioning, okay, as those people age, who's gonna look after me? What have I missed out on with prior choices I was unable to make? Or I made those choices, those decisions based on thinking I was going to not live as long as I'm expected to live now. Can I even express ambivalence and negative feelings knowing others are not eligible for the treatment? And what are my priorities and dreams now? So those were topics that have come up that we know through research. And here's a list of additional topics that have come up both in my clinic and in clinics, other clinics that we've heard from. So, of course, financial challenges, the long-term costs associated with CF. General and retirement savings. A lot of people with CF didn't expect to live this long. They didn't save. They didn't save for their future. They didn't save for a retirement. Many people will now have longer careers. Again, evolving bodies. Disordered eating concerns. Perhaps postponing transplant. Maybe also perhaps thinking more seriously about transplant, thinking that they might live longer. Loneliness, as pointed out, actually, I think the patient's name was Bill, right, with the dog. And survivor guilt. A lot of people with CF now that are aging, they maybe had siblings, they had friends that had that exact same disease and unfortunately passed either before modulators were introduced or they were not eligible. Questioning earlier choices. Why didn't I go to college? Why didn't I learn a profession? Parenthood. Do I want to have children? Can I have children? What would this look like? How do I parent having CF? Again, dying parents and caregivers. Comparing self to same age peers. This one I've been hearing a lot in clinic. Basically people saying, I'm 36 years old and I'm not where I'm supposed to be. Other people my age, no longer live with their parents. They're financially stable. Maybe they've been able to buy a house or, they're married with children. Obviously, the concern of average health concerns now related to aging, which was somewhat introduced already. Natural lung function changes, type 2 diabetes, weight gain, lipids, things like that. And then, of course, there's the approximate 8 to 10% that are not eligible for modulators. And obviously, a lot of what we talk about in the CF world has shifted to people who are eligible, and that's a beautiful thing. But there's also that group of people that perhaps feel a little bit left behind. So what are the evidence-based strategies used by mental health clinicians in working with people with CF? And I'm just going to give you a brief introduction so that if you come across someone in clinic or even just out in the world that you think could benefit, this gives you a little bit of an understanding of the strategies we might use that then gives you the ability to explain it. So the first one is ACT with CF. And this is an actual published curriculum, and I'll, on a later slide, give credit to the people that have published it. It's an actual published curriculum that was somewhat partly funded by the CF Foundation, actually. And it's based on acceptance and commitment therapy. It's a 6-week/6 session curriculum tailored specifically for people with CF, grounded in ACT, which focuses on accepting difficult experiences and then aligning actions and next steps with values. So one of the steps in these 6 sessions is actually identifying what are your values? How do you want to live? How do you want to move forward? And then improving psychological flexibility, meaning the ability to shift the way one is thinking. The second one noted is CFCBT, and this also is a published, structured curriculum and also partly funded by the CF Foundation. And CBT stands for Cognitive Behavioral Therapy. This is a 9-part, 8-week/session curriculum tailored, again, also specifically for people with CF. And it focuses on the relationship between thoughts, feelings, and behaviors. For example, somebody maybe is sitting and feeling kind of anxious and worried about their PFTs that they're about to complete. And they start thinking, what's wrong with me? Oh my gosh, why do I get so worried about this? I need to get over this. This is an issue with me. And then that kind of, creates more anxiety, perhaps feelings of sadness, shame. And then that can affect their behaviors, right? It can affect how they go out into the world. It can affect how they approach their PFTs. Quickly, mindfulness meditation. Mindfulness is basically paying attention to the present moment without judgment. So noticing your thoughts, your feelings, what's happening in your body without judgment, right? Without, like that example I just gave, perhaps that person would notice, ooh, I'm feeling anxious, I'm feeling a little sweaty, I'm feeling a little scared. And they don't jump to then the judgment around that, right? Behavioral strategies such as, getting out into the sunshine, a little bit of movement, and then breathing strategy as well, deep breathing. So strategies that I thought might be helpful for you guys to use. But first I want to point out that not all anxiety or low mood is necessarily a bad thing, right? For example, if I were driving in a horrible rainstorm, I might feel anxious about it, and that might prompt me to drive a little bit slower and be a little bit safer. Another example might be somebody who has CF who's about to travel and they're feeling a little bit anxious about their medication and being able to bring them on a flight. So that anxiety might force them to look at their medication ahead of time, make sure they have everything, perhaps get a letter from their clinic stating all of the meds that they need to bring on the flight with them. So not all anxiety is bad. And similarly with low mood, right? I'm sure we have all experienced low mood, difficult times in our lives. And oftentimes those can be the moments of really amazing growth, right? It brings us to a place of maybe considering, do I need to make a change in my life? So the first strategy that I think you guys can certainly use, and these are like basic strategies that we learn as mental health clinicians, is naming the person's experience, right? Feel free to use the words worried, nervous, anxious, concerned, disappointed, sad. Oftentimes, I'm sure you guys have also experienced this, we might be feeling something and we just feel dysregulated. And when someone names it, we're like, oh my God, yes, that's what I'm feeling, right? So it's helpful to just name it and put it out there. And you can ask or put it out there as like, it seems like you might be feeling a little nervous. Is that right? Or sounds like you're feeling a little sad or concerned about your financial future. The next strategy is normalizing. And this is helpful for all of us, right? And it's basically pointing out to people with CF that many others with CF have similar experiences. It helps them, and when we experience this, it helps us feel not alone with our concerns, right? Some specific examples, I definitely think you're not alone in your concerns about your future. I've heard other people here in clinic mention their worries about finances. Us providers have been hearing from people with CF about the changing concerns about living longer. So those are all examples. And one of the strengths, and I'll touch on this a little bit later too, one of the strengths for people with any medical condition or any concern is being in touch with knowing other people with that same concern, right? So people with CF, knowing people with CF. It's actually quite surprising to me when I say some of these things to some of our patients. They didn't expect that. They didn't know that other people are also now worrying about their finances. So it's really very powerful. Another strategy is validating the patient's experience. So perhaps you have a person in clinic, sorry, this is very RT focused, but who's anxious about their PFTs, and you know that in the past, they would often come in, maybe pre-modulator therapy, and they were often admitted, right? So they're nervous about those PFTs. So to validate that experience and say something like, it makes sense that you might be nervous about completing your PFTs. Is there anything I can do to lessen your worry? So again, and we've all experienced this with friends, right? When we call them and we're saying, oh my gosh, this happened. And the friend at the other end says, oh yeah, I can't believe that happened, or can't believe that person said that. And you feel validated, right? And it feels good. I want to encourage you to offer additional professional support. So obviously your social workers, your psychologists, psychiatrists in clinic, or that maybe are able to contact your patients outside of clinic times. And I want to encourage you to communicate with the other team members as well. I think it's perfectly fine for you guys to say, it seems like you're really worried about such and such. Are you okay with me mentioning it to the social worker or the psychologist who can come in and chat with you about it? They might say no, and that's okay, you offered. And I would even say it's okay to then report to us, this person seemed anxious or it seems like they're worried about things. And let us know that they said, no, they prefer not to talk to you. But at least we have that information. And, we can also very discreetly go in the room and just kind of bring up the topic. It's also helpful for the other providers to have that information. So based on those, I thought we could put this into practice a little bit. So your clinic has a newly diagnosed adult, 55 years old. RT is concerned about overwhelming this new patient with their airway clearance therapy regimen. So naming and validating might look like, I know this can be a bit overwhelming, or I know this is a lot of information. Sounds like you're concerned about getting this all right. Then normalizing. Most people with a new diagnosis do feel a bit overwhelmed when they first get this information. Communicate with other team members, and of course, give the patient informed choice when able, right? If this person is feeling overwhelmed, obviously you need to communicate with the other team members, but is it okay if they don't start this right now? Is it okay if they start after the next clinic visit? So I'm going to ask you guys to think about this next person with CF and think about how you might name what they're experiencing, validate it, and normalize it. So a 23-year-old patient currently on ETI, formerly experienced a lot of hospitalizations due to CF exacerbation. Low PFTs in clinic today. So think about how would you name what they seem to be experiencing, or even ask them about it, and then how would you validate it and normalize it? So I'll give you a minute to think that over. And does anybody want to share? Oh, awesome. Thank you. You get extra points too.
Okay, can you hear me? Okay, so it feels like you're maybe a little worried and anxious, given in the past you've had to be hospitalized for low PFTs. And that's totally understandable, given your history. But this is totally normal. And don't let that fear, disrupt your progress and, performing the best you can during your PFTs.
Awesome. Thank you. So resources that might be helpful to you guys, again, your clinic mental health experts, both CFF and CFRI have peer support groups. And again, I actually think this is one of the most powerful strategies for coping with a medical condition, honestly, any concern. I know CFF also has a mentor program, which can be really helpful, again, connecting with another person with CF. Our clinic also has a mentor program, so perhaps you know of other ones in your area. There's a website, Aging with CF. There's a virtual group for people aging with CF, and there's a support group for males with CF. And then I just wanted to give credit to the authors of the people that created both the ACT with CF and the CFCBT. And I regret not making kind of a summary slide or a takeaway, but I think my biggest takeaway for you guys is name it, validate it, normalize it for sure, use those strategies, and communicate with your team members. Thank you. Thanks. Any questions?
Thank you so much. Did I have this one on? Thank you. Thank you so much. And I'd just like to give Deb an extra hand of applause because she stepped in about a week ago to fill that slot with us. So can we just say thank you? You're a superstar. Does anybody have any questions on the floor, Deb? I'm going to start us off. When you talk about kind of ACT, I mean, apart from the fact in my head, that's always going to be OA clearance.
Yes.
With ACB and the CPDT, what is there one that you would reach for first? Is there kind of a go-to first, or is it just depend on the patient? I'm just kind of interested as to.
Yeah, no, that's
why.
a really good question. I personally really like ACT because of that acceptance piece. The acceptance piece is around one, accepting the medical condition, right? The chronic condition. And two, accepting your feelings and experiences as you experience them. But I would say, I think it depends on how the person presents. If within initial conversations, I get a sense that their thoughts are negative, there's a lot of negative thoughts negatively impacting them, then I would go more for that. But yeah.
Great. Thank you. Anyone else got anything else they'd like to ask them? Okay, so we're going to move on to our next speaker, who's Valerie.
All right, I have my water. We'll make it through. All right, so as introduced earlier, I'm Val Mumper, physical therapist at USC, and I have no relationships to disclose. So the aim for me today is basically to discuss how PT needs have evolved as individuals with CF are now living longer. And the benefit of me going third is now this is kind of a recurring theme. So Gemma had more updated CF Foundation patient registry info. This is back from 2021. But basically 30 years ago, where this slide starts in 1991, about a third of the people living with CF were 18 years or older. In 2021, this is now over a half of the population. And then for the median predicted survival age, so that's the y-axis there on the left, years down on the x-axis, you see, this is 2021, the median predicted survival age was 53, and I think Gemma's updated version 2024 was up to 65. So we can see this trend now. Our patients are living exponentially longer. So in terms of the PT's role, traditional PT, that focuses on conventional chest physiotherapy, whether that's postural drainage, percussion vibration, more of our active airway clearance techniques, autogenic drainage, ACBT. There's still, for sure, a huge skilled need for that. What we're finding, too, is, and I'll see this a lot when students come through our hospital, we need to be thinking about the whole person. Again, another recurring theme, right? So a lot of times when a PT order comes in, I'm on the inpatient side. Sometimes I'll check in with nursing beforehand. Oh, the patient's walkie-talkie, they're fine. I'm surprised PT seeing them. I'm sure a lot of us have experienced that before, right? And it would be really easy if you're a younger, newer clinician. Oh, okay, perfect. I'll be able to, bang this eval out and they're going to be fine. No discharge needs. But really looking at the whole person, regardless of age. So doing our screening, doing our systems review, looking beyond lungs and airway clearance, but for balance impairments, aerobic capacity impairments. If we can catch a patient on the inpatient side and start finding more traditional PT diagnoses, let's start off while we have them here, and we can work with them at potentially a higher frequency, and then see if we can educate them to continue with these programs, in the home setting, or have them then come back and see us in outpatient. But on top of that, as our patients are aging, looking at our evolving PT role, right? So CF care now is this new clinical landscape. We need to have a broader approach to care, looking at specific comorbidities related to patients with CF that now we're finding more and more common that are occurring. So my practice does not focus on peds. So I work in the inpatient setting. We're an adult-only hospital. But as I was reflecting and preparing this talk today, I was thinking, there's probably going to be a lot of therapists in this room who work at pediatric centers. And I would still think that there's a role in incorporating kind of these considerations I'm going to talk about earlier on. Let's get these patients set up for more quantity and quality of life as they start to age. So in 2024, there's this review, Felipe Montiel. He discusses how CF is evolving as a chronic condition in the era of CFTR modulators. There's lots of studies that highlight kind of these emerging medical comorbidities in CF. So on the left-hand side, that's kind of our common CF complications that we're used to seeing. And then on the right-hand side, kind of this laundry list of emerging CF comorbidities. I wish I had more than the 20 minutes to talk through, potentially PT's role, right, in helping our patients kind of manage and thrive with these comorbidities, but I'm just going to focus on a few. So the first topic is sarcopenia. So what is it? I think we're kind of maybe more comfortable with this medical term, right? Loss of skeletal muscle mass, strength, quality. Why does it happen? This is specific to CF, right? So kind of this chronic inflammation, oxidative stress, malabsorption of nutrients, if they have a pulmonary exacerbation, maybe being a little bit more inactive, and then that just kind of exacerbates this muscle loss. For sure, chronic corticosteroid use, especially around hip muscles or proximal muscles. Hypoxia, chronic infection, we kind of talked about that in the first piece. But why does this matter? Well, it can lead to frailty. And of course, thinking, yes, frailty is bad. We don't want to be frail. We want to be stronger. But why does that matter? Frailty is associated with increased risks of poor outcomes. So for the transplant population, frailty is something that the interdisciplinary team will look at to even be able to assess a patient's candidacy to be listed for transplant. And a higher frailty index is associated with higher post-transplant mortality. What if your patient's not quite there or not interested in transplant? So even in those populations, being pre-frail or frail correlates with more frequent pulmonary exacerbations, reduced lung functions, more hospitalization, poor quality of life. What about increased risk of falls? Why is that a big deal? So, with the aging population, our patients are, tend to be at greater risk of falls. And for, this reason, right? Muscle weakness. But for people with CF, and I'm going to talk about this next, CF-related bone disease, falls pose an elevated threat because of risk of fracture. So mitigating fall risk for these patients is critically important. So in terms of PT considerations, what can you do? So of course, you're going to be going through your systems review. One of the things we always look at is assessing strength. Maybe you can do it in a way that's more functional, like, it's maybe not MMTs, manual muscle testing. Maybe you do like a 5-time sit to stand that looks at lower extremity strength power. Maybe you can do something that assesses more functional performance. One of my favorite objective outcome measures is the short physical performance battery, the SPPB, right? So I think a lot of us are familiar with that. It's a 3-component test, so SPPB. So it's a 5-time sit to stand, there's a 4-meter gait velocity, and then there's a standing balance progression. And then that will assess frailty, and it's something objective you can bring back to the team and then measure, in subsequent visits. Plan of care, of course, if you're starting to notice that your patient is becoming weaker, whether it's something you pick on in subjective or with your functional assessment, right? We have to start that resistance training, even if it's during an exacerbation and they're not feeling well. And you can provide education as why is that's important, so that way, hopefully, they take it with them as a home program. Okay, so the next, CFBD. So if I'm an inpatient therapist and I see this in the chart, okay, they've been diagnosed with this, right? I'm going to actually consider this in my management of the patient. So it's not just something that I write in my diagnostic impression statement, 50-year-old male, history of CF, CFBD, and then I don't, do anything later in my assessment or intervention related to this. No, let's really take a minute to talk about this. So what is it? Okay, decreased bone mineral density. Okay, why does that matter? So patients with this decreased bone are at a much higher risk of developing rib or vertebral fractures. So we think about kind of, especially if there's a chronic cough, all this high intrathoracic, intra-abdominal pressure, and they're just going to be at such higher risk of developing these fractures. Why does that matter? Okay, so maybe they'll develop more postural deformities like kyphosis or rib cage restrictions. Everything is painful. So we've all probably worked with patients at some point or another who've had a rib fracture for whatever reason, right? So anything that increases that pressure is going to be painful. Coughing, sneezing, laughing. So what do our patients do? They avoid that. So they feel a cough come on, they try to suppress it. So this can affect their ability to clear their airways. It might deter them from exercising because it hurts to take a deep breath. So I'm not going to push myself while this fracture is healing because it hurts to exercise. So I'm just going to take it easy and not do that. And then you start to see their exercise capacity decrease. So what can we do as PTs? So, let's incorporate, if we see that our patient has CFBD, let's incorporate this into our evaluation of them. Like really take a look at their posture, really take a look at their body mechanics. Is there an opportunity to educate with how they're moving? Whether that's helping with lifting mechanics, or just strengthening, is there a role for us here before they continue to age and maybe fracture, and then it's just a cascade of more pain, more fractures, more inactivity. So our medicine is exercise. So of course, let's add in some weight-bearing, resistance training, impact training to really load that bone and strengthen it. European guidelines recommend exercising 30 to 45 minutes, 3 non-consecutive days a week, and incorporating resistance activities that really promote the bone loading. So like skipping, jumping, as silly as it sounds, but it can be fun, right? So what's great now is, people are more comfortable maybe in their homes, especially after the pandemic. So I'll say, just put on some silly music. Let's, do this, silly jumping exercise. Let's just make it fun. Whatever you can do to add loading. So for example, instead of doing a simple heel raise, coming up onto my tiptoes, right? Can I come up and then drop? It seems so counterintuitive because normally as PTs, land quietly. Let's get this good eccentric contraction. I hear you, you're too loud. No, let's try to do a drop. Let's really load. So it's just thinking about how can you modify your exercise as your medicine to get the biggest bang for your buck. And then, of course, prevention and education, right? So going back to that, I mentioned earlier, how can you teach your patients to do activities where they're at less risk of fracture and kind of going down that negative cascade? Okay, CF-related diabetes. So we know this is kind of a distinct form of diabetes. There's features of both type 1 and type 2. You can read, kind of why it happens within this group. But why does this matter? And why does this matter if we're a physical therapist, right? So, just simply, having this kind of diagnosis or comorbidity, we know that it can kind of decrease lung function, weight, muscle mass. It can increase their likelihood of having more frequent pulmonary exacerbations and thus hospitalizations. So again, our medicine is exercise. So there's a role for resistance training. There's also a role for aerobic training, cardiovascular training, right? Can we help to improve insulin sensitivity, glucose uptake? Really trying to build up slowly, so it's not too overwhelming, but slowly to a goal of over 150 minutes a week. If my patient that I'm seeing has CFRD, I'm also going to be thinking in the back of my head, they're at greater risk for microvascular and macrovascular disease. Okay, well, how does that impact me as a PT? Well, okay, if they're at greater risk for retinopathy, then perhaps I assess balance taking away vision. If they're at greater risk of neuropathy, maybe I need to go in and do light touch sensation. Do they have protective sensation, right? Are they at risk of wounds? And then CAD, PAD, perhaps you're a PT in an outpatient setting and you're starting to develop your patient's aerobic program, and you're maybe one of the first people to pick up on, oh, they have intermittent claudication. Maybe they have PAD. Maybe this warrants a referral back to the MD to kind of get their thought or, maybe look into this further, right? So it's just kind of looking at diagnoses maybe we see a lot, but what are we going to do? How is that going to change our care? And then, of course, safety considerations, right, for blood glucose, checking before you do this strenuous activity, monitoring during activity for symptoms of hypoglycemia, and then afterwards, the education piece, right? Let's hydrate, be on the lookout for these signs that would indicate that you have really labile blood glucose and it might be dropping. Okay, lastly, I think I'm doing okay on time, pelvic floor dysfunction. So again, probably not a new topic for us here, but what is it? Okay, so urinary incontinence, mostly urinary, stress urinary incontinence to be specific. But how would that affect me as a PT? And I'm not a pelvic floor PT by any means. All right. So just knowing that a patient has pelvic floor dysfunction would, of course, change the way that I would prescribe my medicine, which is exercise. But what about being maybe the first person to pick up on if they have pelvic floor dysfunction? And especially in our older adults, we'll see this, where they've had more and more years of potentially chronic cough, weakening. So, one thing I just had to make sure that I included was a self-reported outcome measure just to even screen for this. Because I think sometimes it's so easy to just kind of get caught up in needing to get through all of your assessments that sometimes this gets missed. So let's just screen if patient scores high on this, higher score is worse. It's a very easy self-reported outcome measure. It's pretty much like 4 questions. Then you can start incorporating the education piece, right? Very safe. This is just us talking. I'm not doing anything invasive. And then let's add this into our exercise program, right? So whether it's something as simple as, pelvic floor activation before I do that bone loading exercise, right? So to illustrate a point of, biggest bang for your buck, perhaps I engage my pelvic floor first, then I have them do the concentric exercise, to at least get some sort of resistance training, weight bearing, and then I do the drop, where they'd be more likely to have the incontinence piece. So when I'm patient facing, it seems, less intimidating, right? Like, let me just give you three exercises, 3 to 5 exercises. Let's just practice these while you're here inpatient. And then when you go home, you can continue with this. And this is how you'll, build in terms of sets and reps, right? So it's like not intimidating at all and maybe more doable and realistic. But really so much more thought goes behind exactly what I'm picking, tailored to that patient based on, okay, CF, but then also what other comorbidities, do I have the luxury of having because the MD diagnosed it, right? Or, am I picking up in my PT exam? So, in summary, as PTs, we help people with CF thrive through every stage of life now. That really means widening our lens, looking beyond just airway clearance to address the evolving needs and to truly provide comprehensive care throughout their lifespan. So references here, and I can provide them later too. And I just wanted to add my email if any questions come up, later during the conference or afterwards. I would love to collaborate and learn together for the betterment of our patients. Thank you.
Thank you so much. That was brilliant. Does anyone have any questions for Val? Just double checking. Just wanted to start with, so you mentioned about frailty, and this was a super hot topic in the European conference this year as well. And there was quite a lot of debate about what's the best way to assess it and what's the best kind of assessment tool. What's your favorite?
Yeah, great question. And I know for a lot of other organ transplants, there's specific indexes for frailty. Like liver has their own frailty index, right? And lung, this is a hot topic. One of the things that we're looking at our center is there the best outcome measure to assess this? Right now, the PTs will do the SPPB. The OTs, they also have kind of their own outcome measures that they do. They do like a 60-second chair stand. But for us, I found the SPPB because it's the chair stand component, another balance component, and the gait. And then we'll also do an aerobic capacity. Curious, I know that there's a lot of other experienced PTs in the room too. Like this can be just a think tank if anyone else wants to add.
I had pretty much the same question. I was going to ask in a busy clinic, what are your go-to? I know we typically do the 1 minute sit to stand, but have started talking about for the older people that may be at higher fall risk. I have done the SPPB with them. So it was basically the same question.
No,
so
it's
I'll
a
just say
great
thank you
question.
for a great talk, and thanks to Jen and Gemma for running a great session.
Appreciate you. Yeah, the one thing I will say, for the SPPB that I do love too is it was originated for community dwelling older adults. And it does have a component when you look at the score, not just to assess frailty, but also risk of rehospitalization. So, it can be used in clinic or it could be, in the inpatient setting, really appropriate. Yes.
Probably more of a comment than a question. I was just sitting over there and like nodding the entire time because I feel like you kept saying things and I'm like, I experienced that too. Another thing that you might also get is a lot of my patients in clinic, like they'll be like, oh, well, like this isn't really a CF problem, and so I think a lot of our older adults like think that when they're seeing us, like, oh, like we have to address all the CF stuff. But honestly, like a lot of their mobility issues or things that are coming apart are just like, they're getting older. So I feel like us like bridging that gap between like, it might not be specifically CF related. It might be related. It might not be, but like kind of working with them and like, this is just what we need to do now. Right. If that makes sense. Like kind of getting out of that pigeonhole of like, okay, boom, boom, boom. These are like the 5 issues that you should have with CF today.
I love that comment, right? And I think a lot of times as PTs too, they'll open up to us maybe because we can ask other questions and really kind of pick up on, this is just aging. And you know what? Like you can do more and you can get stronger and better. And like, let's do this. Let's work hard. And it's exciting. It's an exciting time.
Yeah. But thank you for all the work you do. And I was sitting there like, yep, I hear that too.
Thank you.
Thank you very much.
Thank you.
The frailty I've been looking at our clinic as well. I worked part-time for a home care agency, and they used which I've adapted into the CF clinic, the fried frailty phenotype.
Yes.
which is actually pretty easy to do because you're asking questions of the patient. And so they're pretty quick thinking about time in the clinic. Gait speed, weakness, which is a hand grip test, and unintentional weight loss, which would be in the EMR. So I'm using that and collecting that data and looking, and luckily it hasn't come back with a lot of patients positive. But I think it's just because I haven't been able to see those patients in the clinic itself, but I am taking a look at that using those parameters. So
Thank you for sharing that. And I love that because it has a lot of crossover with other organ transplant, like the LFI for liver has the hand grip strength. And so I think that that's great. We should start incorporating that more.
yeah, I found it was very simple to do, very easy, and it didn't take some of the stuff I can get done before I even see the patient, and then it's just gait speed and hand grip tests.
Thank you.
Yeah, and the gait speed is really, really low. It's really slow. Taking more than 12 seconds to walk 3 meters.
Oh yeah, that is really slow.
Like, so it's almost like I can watch the person walk it. Okay, they're fine.
Like you already know. Yeah. We can check that one off.
It's just sounding like we need some sort of international gang to decide what the best thing should be.
So I work in a pediatric hospital, and we see up to the age of 21. And a lot of times I feel like in the teenagers and like the old or the young adults, that when we do like an inpatient evaluation and say they are independent with mobility, and they're not super excited about participating in some form of exercise while they're inpatient, we just kind of like sign off, and we'll maybe like monitor them, like check in a week and make sure everything's still going well. What are your thoughts on like trying to promote, like, we need to see you while you're here to prevent deconditioning? Like, or what are your thoughts on doing some form of exercise while they're inpatient?
Great question. I'm not going to answer this as a PT. I'm going to answer this as a mom. And what I'm learning as my kids are getting older and older is that sometimes they need someone else to tell them what to do that's not a parent. So I've never been in that, position before, because everyone we see are adults. So it's easier just to kind of level with them and just say, yeah, I know you're not feeling well. We have to do this. But I think if I were in that position, I would really try to be obviously personable and empathetic, right? But just like this, we have to do this. I'm here. We have to do this. We'll try to make it fun, and maybe try to sneak in the education component that would be appropriate for their age. But sometimes I think that as a parent, I get so tired of saying the same thing again and again, and I feel like they don't listen to me because I'm mom, that if someone else can come and with like more of a medical background, that maybe they would listen better. I don't know. I would open that up to the room for the peds therapist. I think that's a great question.
I would just add, from a mental health perspective and even a parenting perspective, if you can give them choice, right? We really do have to do this. We can do it now, or I can come back this afternoon, right? Yeah.
Okay, we have one more that's come on the iPad. So do you work with a dietitian for CFRD patients on nutrition before exercise?
We do in select cases for sure, and try to collaborate across disciplines. Because it's true, right? When you're starting to exercise more, you're burning more calories. You need to make sure that that's being supplemented with proper caloric intake and the right stuff. Are we getting enough protein, especially if we're trying to really build muscle in those patients with sarcopenia? So I think excellent point. I should have touched on that here. As much as you can collaborate across disciplines, the better.
Brilliant. Thank you so much for your talk.
Thank you.
Okay, so we're on to our last talk, and this one's our video from Daniela Bossini Auli. So we're going to start it, and I'm hoping you can hear it. I have my fingers very crossed. Here we go. Just hold it for a minute.
Try again. Yeah. That's sounding better, right? Brilliant.
My name's Daniela. I'm 51 and I have CF. I was sick my whole life, but they just didn't know it. I was born in Brazil, but I was diagnosed when I was 29. In Brazil, they never taught about CF my whole life. I was sick first time when I was a baby, so there are no pictures of me as a baby. I was sick often, not necessarily from lung infection, but I always had this cough my whole life. And I would get sick very often with sore throat, or it was sinus. It's something like this cough that would never go away. So they thought it was tuberculosis. I was in the hospital for a long time because they saw an image in my lungs and they said, this is tuberculosis. And they treated me for it. And I grew up like that. In my early 20s, I started getting really sick with lung infections. And I was getting worse and worse, and my lung capacity started dropping from 100 to the 70. And when you have that drop, basically you cannot do physically what you used to do. My lungs were constantly full of secretion, and there was this bacteria called non-tuberculosis mycobacterium, which is extremely resistant to medication. And that bacteria was damaging my lungs and it was out of control. There was no medication that could stop it. I had been sick for, 7-8 years, repeatedly lung infections. And when I was 29, I was at a meeting at work and I had to hurry to the bathroom. And I started coughing a huge amount of blood. And I called my doctor. He said, go to the hospital right now. Went to the hospital. They admitted me into the ICU. And I was there for a long time. And then a new doctor there, he started investigating. Why do you have this specific bug in your lungs? That's not common. And he suspected it was CF. And then he did a DNA test, and it was. There's no cure. The average age is 36. And I was so sick that I couldn't think that far ahead. I was just, okay, get me better. And he said, but we don't really have treatment for CF in Brazil. We don't have all the medication you need. We don't even have the knowledge about CF. That was 2004. Luckily, in 2005, my husband Perry's employer transferred him to work in USA. And we moved to USA. And I believe that saved my life. I was extremely sick, but I started the proper CF regime with all the medication, PICC line, antibiotics. I was in a hospital for, I think, for a whole month, but at least I was getting the proper treatment. Everybody speaking English around me. I couldn't understand anything. And then we found a Brazilian doctor, infectious disease doctor. And I started treating, was in a hospital for a while, and I was extremely sick. I was in a wheelchair for a while, but I got better. So my body, I guess, was very resilient. My treatment takes about 3 to 4 hours every day. So I wake up early, around 5:30. I have breakfast with Perry, and then he gets ready to go to work. Sometimes he goes to the gym at 5:30. And then I start my CF treatment around 6:30 or so. First is nebulizer. So there are 3 medications that I have to inhale through a compressor nebulizer. That takes me about 30 to 40 minutes to do that. Once I get that medication in my lungs, I like to go to the gym. And I usually go to CrossFit gym and I do a workout. While I'm working out, the medication is there in my lungs. So medication start kind of loosen things up. And then as I exercise, then things move more. And that's good because the secretion is coming from the bottom of my lungs. I feel when I exercise, that secretion starts coming out of the places. And that's why I cough, because it's moving. And that's a good thing. That medication is working inside my lungs. And the exercise is also working, making my lungs work. So it's a combination of both that is part of my treatment. So I get out of CrossFit, come home, and it's still not time to cough it out yet because I can feel. When I get back home from the gym, I put a vest on and I use that vest for about 20 minutes. After the vest, I have to do a postural drainage. That works for me about 5 minutes. I basically lay upside down. By that time, which is going to be around 10:30 a.m., I can feel the secretion is ready to come out. So I get out of that position and I do a little bit of huffing cough. You know, it's like, you breathe in, you hold, and then... And at that time, I start expectorating all the secretion that's in my lungs. So once that's done, I feel, okay, now my lungs are clean. Then I have to inhale an antibiotic. It takes me about 10 minutes. Then I can start my day doing other things. I work from home as an attorney, so I'm basically in the computer during the day, and then dinner at home. I usually cook every day for my husband and I go to bed early, actually, 8:30, we go to bed. My lungs right now are at 62 to 65% lung capacity, but I don't know how it is a normal lungs. With the disease, it's a day-to-day learning. So in 2014, there are some breakthrough medication that I started taking. Before I started that medication, I was sick every 2 months. I would finish a treatment with antibiotic, PICC line and everything. Within 2 months, I would need different antibiotics because I had 3 different bacteria in my lungs. Then I started this first breakthrough medication, which was Kalydeco, and that helped. I no longer had exacerbations as often as I was having. And then in 2022, I started a new medication called Trikafta, and that medication helped even more. So I like to say that right now I have only one bug that concerns me in my lungs that I treat with the antibiotic daily, but I no longer have the other bugs that were also concerning me. This breakthrough medication that I'm here alive and having the chance to take it. Science is amazing. Like, it saves lives. It's saving my life. When I left Brazil, I lost a lot. I gained a lot because I was getting my CF treatment, but I never wanted to leave my home country. I left my family. At that time, my career was the most important thing to me, and I was at the top of my game, and I had to leave everything behind. So when I came here, after I was feeling better, I said, what am I going to do? I cannot just live for CF. So I put myself to English school, learned English. Then I went to law school. And then I said, okay, now let's take the bar. And I took the bar and I passed. and I started working as a lawyer. I had to bring back to my life some intellectual challenge that would make me proud of myself. And then physically, I was feeling so limited at that point until in Savannah, Georgia, I stopped at the CrossFit gym and I said, let me check that out. And I saw some people doing those crazy CrossFit things, and I turned around and said, no, I'm going to go home. But then I saw a group of people who looked like normal people, and I went there and I said, can I join this group? And they were beginners at CrossFit, and I joined them. And I started CrossFit. That was 10 years ago. I loved it. And why? Because even though I was limited in my lung capacity, but I was able to do things that even like my friends, they say, I can't do that. Working out with the barbell or the gymnastics movements that we do, it brought me also back what I had lost physically. CF took away my career, my physical capability, but I found that back both. There was a point that something shifted in my mind and I said, I will stop asking what I cannot do, and I'm going to ask what I can do. And so I did it. Right now, what gets me is I feel guilt because I'm alive. I met many people with CF since I was diagnosed, and most of them are no longer here. And they died much younger than me. So it's a feeling that doesn't go away. It's kind of a pressure, but in a good way, that I'm living here not just for myself, but for them. And in my mind, I have to take every opportunity and do my best and succeed because I'm alive. What I think is that everything that I do, I want to honor these people because they are no longer here. And they were fighters. They were not giving up. They were doing their treatment like me. But why they are no longer here, that gets me. And I am. I am part of a cystic fibrosis quality improvement group with Johns Hopkins, and actually all of the CF clinics in USA are part of this. And I'm there as a patient to help to improve life of CFers. We are aging with CF, and that never happened before. So as a team, we are like, how is it aging with CF? No one really knows. Science doesn't know. Mental health it's a piece of that. So dealing with the disease, I guess any chronic disease, you just go on a day-to-day doing what you have to do to feel better, that you don't actually stop to think, how am I? During the pandemic, Johns Hopkins started a mental health study, and they said, Daniela, can we send you a questionnaire? I said, okay. So I answered the questionnaire, and they came back to me and said, look, there is a yellow flag. I hadn't realized, because to me, those feelings that I was feeling, it's just the way it is. I was having anxiety, and so I started a therapy with them, and it was one of the best things that I did, because I learned things about myself. And I learned what works for me when I have anxiety or I'm getting sad or something. I need to do something with my hands, because then my mind can focus on something that I can control, actually, because I cannot control CF. One of the things I did, I learned how to sew. I took sewing class, and that helps me with my mental state, because when I'm feeling a little bit on the edge, I go to my closet and say, oh, let me find something that I can fix. And I go to my sewing machine and I fix it. Right in front of me, I was able to control. I need to do this, I do it, and I see the result right there. So when I started having symptoms of perimenopause, night sweats, brain fog, joint pain, extreme irritation, mood swings, we didn't know if my symptoms were related to my medication. It could be related to CF, because CF affects your bones. We just didn't know. And you just keep going thinking like all of this is because of CF. Because before, who with CF would go through menopause? But now we are here. We are 40, 50, 60 with CF, and we are going through perimenopause, menopause. And then I actually went to a menopause doctor from Johns Hopkins, and she made me think, maybe it's not all CF, maybe it is hormones. And I started a hormone therapy 4 months ago. I have no more pain in my joints. It's gone. I don't have night sweats anymore. We are learning as we go, because everything that I feel, any symptom that I have, it seems it could be related to either CF or a medication that I take. But it could also be perimenopause, menopause. Then there are no studies out there about that. But now we are talking about it, and we are bringing that. You know, the CF Foundation is also talking about that right now. So hopefully we are going to have more information and studies that can give us some, information on what to do when you have symptoms, right? How do I know if it's medication, if it's CF, or if it's menopause? It's all connected. My hope for the future is, I love to help CF people, and I think I'm doing that, working with these groups and talking with patients. I talk a lot with mothers who have children with CF, and just by talking to me, because I'm 51, it gives them so much hope. When I was diagnosed, the life expectancy was 36, and now it's, I believe, 65. And I have a cousin who was born with CF. He was diagnosed as a baby in Brazil, which means things are much better there now. And I feel good that I give hope to children with CF, to their parents. And many of them are in Brazil, and I'm able to talk to them and say, hey, you have wonderful science right now, and in Brazil you are getting the medication, you are getting treatment now. And I'm here, I'm proof that your kids are going to live. Just keep doing what you're doing. Don't miss treatments. Don't think that, your lungs are better. You have to keep doing it. It's not who you are, but it's part of your life. I believe the next generation of CFers who reach my age, they're going to have so much more information and studies and science. I'm so proud of this group because I can see how much we're going to help. This group is helping me already But I believe the next generation of adults with CF who start aging with this disease, they're going to benefit a lot from the work that we are doing as a group.
Okay. Now, unfortunately, Daniela couldn't join us, so we haven't got kind of questions for her. But if anyone does have any particular comments, we will pass them on to her. She has asked for kind of to let her know how this session went, so do let us know. We do have time for a bit of a discussion. So if anyone has any questions for any of the panel that they want to put, or just throw out an idea about kind of aging issues, please do that. We've got about 10 minutes to do that. And I think the first thing, when we were talking about setting up the session, we were talking about the late diagnosis. So, we are picking up people much older who are being, suddenly hit with a diagnosis of CF. And I guess the question kind of to the gang is, what do we do first? Because, you don't want to throw everything at somebody who's just got a new diagnosis. So what would be the advice and the tips?
I came here for the tips. We've had, like a couple months ago, we just had an 85-year-old new diagnosis. We have an 87-year-old coming in a week. So I feel like, and we have great providers, but I feel like our providers want one thing and the patients are just saying yes, yes, yes with the providers in the room. But then I come in and I'm like, there's no way they can do this. So that was why I was excited about this symposium, is just getting people's advice and input on this. If anyone has any.
I think at least for PT and, in terms of what we would be adding to their already overflowing plate, talk about keeping it digestible, right? Give them bite-sized chunks of, let me give you one thing, right? Let's just add this one thing, because the fact of the matter is, right, like if it's too much, it's not going to happen. So I would rather start small and have them be successful with that. And then the next time I see them and check in, how's that one thing going? Okay, let's modify it, progress, regress, and then maybe, you can get a sense of if they can take on a second thing. And then just little by little adding it to their plate, because I think you summarized it beautifully earlier. It can be very overwhelming. And so starting small and building is what I found to be the most successful.
I'll add on to that a little bit. From a kind of mental health perspective, or even just social work perspective, I usually just kind of try to read the room. How much can they take in right now? How much do they want? How much do they need? It could be a super long amount of time with me, or it could be super brief. But I think one of the most important pieces is an initial introduction, because certainly mental health related topics are not easy to talk about. So it's really about building a relationship, being available, starting to build rapport, let them know that there are people on the CF clinic staff that want to talk about these things, that want to be available and hear about the challenges, because that is very unique, that whole multidisciplinary clinic.
I think also kind of where we work, we pick up a lot of kind of older diagnoses. And I think there's part of me that's like, they've made it to 87 or they've made it to 65 with whatever they're doing.
Exactly.
I don't need to chuck the entire CF tank at you at the same time because you're there. So it's, again, probably I would talk to them, like assess them as an individual, like what is the main thing? What is the main problem that we've got? Is it that they've come to us because they're getting sicker because they've, suddenly got like a pseudomonas or something, and then, okay, we're going to go down the nebulized therapy road. But yeah, so it's the individual kind of therapy, and then, yeah, bite-sized chunks, definitely.
Yeah, absolutely the individual. And I was going to say, when we get these new diagnoses, I may or may not go in the first visit.
Yeah.
And if I do, it's maybe just an introduction, face, name, brief highlights of role of PT on the team. And I think it's more about, the physician, the nurse, whoever's going to go in and get more of that history, what are their priorities for that first visit, for the second visit, and who on the team needs to go in? And are they eligible for a modulator? And if they're going to be starting on a modulator, let's not do the airway clearance thing just yet, to not overwhelm them. But like you said, just treating them as an individual, letting them know what their options are, that we're partnering with them, starting to build that relationship to establish trust, because it is, I can imagine, like 100% overwhelming to, like, you get this diagnosis and then you go to see the doctor, but the doctor becomes a team of, 6 people or however many people are on the team. So really just, bite-sized chunks is, put beautifully. But yeah. That's my 2 cents.
Agree. Anyone else have any other thoughts? Have we got anything on the iPad? Any other discussion questions? So one thing that I was just thinking about when we were kind of listening to the talks was about, has anybody changed where they're kind of advising patients? So, now that we know that potentially people have got, much longer lifespans, is there anything advice-wise that you're changing in terms of, exercise suggestions or life planning advice or whatever that you maybe weren't doing before?
I'll quickly jump in. I think what I've been seeing and what jumps out at me even more so, I feel like I keep repeating, connect with other people with CF, connect with other people with CF from a mental health perspective, because your life has just significantly shifted, right? With living a lot longer, most likely living a lot longer. And to try to muddle through that alone can be really hard, can make one feel lonely and alone. And there are a lot of really good venues to connect with other people with CF. So I think that's been my biggest change, actually.
Quick tail question on that, because prior to modulators, they could not be within close to each other. And they kind of had to isolate. And I was in the stage of, when we enacted that, when patients were angry, they were very, very mad at this reverse isolation. So what are your thoughts on that? Now with patients on modulators, do we still feel that risk is as high? And one good thing out of COVID is we can do telehealth, and we have, kind of created some better opportunities that way. But thoughts on that?
Yeah, I do want to add that the ways I'm encouraging them to, thank you for that, because that's super helpful. The ways I'm encouraging them to connect are things like the support groups that are like CFRI sponsored or what have you. And those also have clinical social workers who are facilitating the group. So there are experts in there kind of just keeping things at a certain, level and making things move along, but they are virtual. Yes. And then there are opportunities for in-person, as far as like, again, I'm a huge CFRI person. But they have like in-person retreats. And so they're super careful, right? People are masking, they're maintaining distance, things like that. So yeah, good question.
Just on that, I'm a part of the CFF and UKCF Trust Working Group on Infection Control Measures, and that's not going to change. We are still not going to allow people to mix. I mean, I don't particularly like the 6 feet rule, because I think Pseudomonas, we know that it travels 4 meters. That's further than 6 feet. So that fact is not going to change. We're writing up that you should have it in the next, I don't know, maybe year or half a year, by June, maybe next year. But that's a definite point that's not going to change. It's too soon, and they still are growing pathogens.
Yeah, I think some people, I'm not coughing, so I'm not spraying it, and it's still, like Lisa said, that it's still in people's lungs. There's still the potential for that airborne travel. So yeah, it's still definitely a risk for people. Okay, any other questions or thoughts? I did pick up a question on the iPad about, can I talk about yoga CF and geo hours? Absolutely, but probably not here. There's a poster, so we're on poster 118. I will be there tomorrow when I'm supposed to be standing there, so please come and find me if you want to hear about yoga CF, because I'd love to talk about it. And I just want to finish the session by just thanking our speakers and thanking the brilliant Daniela and my co-chair Jen, and also just giving a huge shout out if you are, interested in aging. Obviously, the plenary tomorrow, A Breath of Fresh Age, Redefining Growing Older with CF, starring our amazing PT, Karen von Berg, which we are very, very proud of her. So, please do go along to that to not only support Karen, but also to hear some great talks. So thank you all for coming this afternoon.
And thank you, Karen, for helping me with the beginning, even though you had to drop out for the plenary. I do appreciate all your help.